Thank you, Zoe. Thanks all of you for being here, both in person and virtually. And I really want to commend Zoe for putting together this program. It really has turned into something you should be proud of, and we're all very proud of. So I want to get started. Hot take: dysplasia, surveillance, and colitis. The key here is assessing risk for these patients with colitis, and how often should we be scoping them? Actually, when should we start to scope them? How often should we scope them? When should we stop scoping them? And I'm going to touch on which technique to use, and I'm going to cover everything: chromo, high definition white light, NBI, standard light, and even random biopsy. I'll explain my own personal practice, and then I'm going to talk about some work that still needs to be done. So just to briefly review the natural history of dysplasia in colitis, back in the old days when we used basically candles to look at people's tuchuses to look for dysplasia, practically using fiber optic scopes and very low resolution scopes, the onset of dysplasia to the onset of cancer was really a bit of a black box. We were really not sure. All we knew is that it would come fast and furious with these patients. They would have onset of symptoms. The cancer diagnosis could often be made with a sigmoidoscopy or a colonoscopy or a digital exam back in the old days, and then they died. With the lower resolution scopes, as the endoscopic era, colonoscopic era came in, more often we were bumping into dysplasia with random biopsies, or even finding what were called in those days DOLMs. These could be basically a preface to a surgical intervention. It was very unusual until Peter Rubin suggested that we do this here at Mount Sinai back in the late 90s, that these patients could actually be managed endoscopically. With the high resolution scopes came a much clearer view, and then with augmentation of these higher definition scopes, such as chromoendoscopy and later some of like narrowband imaging, what have you, we've been able to more fully and safely and confidently monitor these patients, survey them, and keep them safe from getting colon cancer. So you find a dysplasia, you can resect it, and then manage them over time and over years, hopefully avoiding a colectomy, such as here, but overall, hopefully avoiding cancer or cancer death. The problem, as the definition of the scope started to increase, the overall incidence of colorectal cancer also started to decrease. And there's a lot of controversy about why this happened, but there's general consensus that it probably had to do with the fact that, one, we were removing more dysplasias as we were doing these procedures, thus cutting it off at the pass, so to speak. And we were treating these patients better. We were getting them into a much more durable, thorough, in-depth remission. And therefore, without that inflammatory process provoking carcinogenesis, perhaps that is part of the reason. Anyway, this has continued to stop. The hockey puck of the Eden era in 2001, which is what I grew up with, I assumed I was going to see a tsunami of colon cancer very early in my career, has dropped. And has dropped even further since Jess's paper 10 years ago. So assessing risk of a patient in terms of when you start and how often you do it, you have to take into consideration several things, and this is still the case even in this relatively modern era. The age of the patient actually matters, the extent of disease, the duration of their disease, whether or not they have a PSC, and most importantly, whether or not they have previously had dysplasia. That's an important one. All of those can increase the risk. Family history is important. Lynch, in fact, I'm going to say a decent number of the colon cancers, of the few that I've encountered over the last 15 years, 3 of them have been Lynch syndrome that was picked up incidentally. So it's very important to be aware of that. I don't think we should be screening those patients preemptively, but it's something to keep in mind. Pseudopolyps, ironically enough, in the past were a common reason for sending people for colectomy because we weren't confident in how we could survey these patients. It ends up that pseudopolyps appear to be somewhat protective against dysplasia and colorectal cancer. And as a result, just a careful exam using a high definition scope, preferably with chromo. Disease activity cuts both ways. If somebody has an active case of colitis, I'll talk to you how I manage it and how it's recommended in most of the guidelines. But if their activity over time has been very low, they've been in a deep abiding remission, then that's good. That reduces their risk. If they're chronically inflamed, then it's the opposite. In general, for UC and for Crohn's colitis involving at least a third of the colon, that's who I'm talking about today. If somebody has a little bit of proctitis or they only have a little bit of colitis of Crohn's, it's going to be less often. 8 to 10 years after their diagnosis, every patient needs to be enrolled in a colorectal cancer surveillance program. If they have IBD with diagnosis, it starts the day you diagnose the PSC. You have to start right then. A few years back, and it used to be that people were very intensively surveying these patients, and it was an enormous burden on the patients. And the British Society really pioneered the idea that we can really categorize them by risk. We don't need to be scoping people every year or even every other year. We can actually look at how active their disease is, how often they've had previous dysplasia. And the British Society really should be commended. So they have sort of a 1-3-5 setup. Again, if there's active disease, they should probably be coming back every year until you get them in a remission with medical therapy. If they have PSC, they really ought to be coming back. If they have previous dysplasia, they need to be coming back yearly. Then there's intermediate and lower risk. Again, some controversy. Not all of this has been adopted, but once this came out, it started to gradually seep its way into all of the North American, Asian, and other European guidelines. So to the point now, when you look at almost all the guidelines, there's much more overlap in terms of every 1, 2 to 3, or 5 years that you should be scoping these patients to prevent them from getting colorectal cancer. So which technique to use? And I'm not, everybody knows my preference, but I just want to really just make sure you understand that the boxes you need to be checking in the post-scenic era, you have to not just be detecting dysplasia, you need to be defining it, and then once defined it, determine whether or not it's something that can be resected and managed endoscopically. That's really your mission. So if it checks all the boxes, then I'm good with it. So at the very baseline, the foundation for everyone, it needs to be a high definition scope. The prep should be excellent. My own preference in my own practice is water intubation. I find that it takes care of a lot of the mucus, which is really the enemy of a thorough look in the colon, and they need to have quiescent disease. Chromoendoscopy has performed better than NBI in general, and I did you all a favor of going through all the meta-analyses that have been done, and this is sort of my own hot take on it. Chromoendoscopy appears to be better than NBI. NBI did not perform as well as high-definition white light. Again, my own sense of why that is that it's dark, and you don't see as well in the dark. That's just a general rule of our visual biology. A high-definition white light either approached or did not quite perform as well as chromoendoscopy. Standard scopes, which 25% of American endoscopy units are still using standard definition scopes. It's a very important thing. Only 75% penetration with a high-def scope still. Apparently, it's worse than just about anything except random biopsy, which I'll get to in a second, unless you're using chromo. So if you have standard definition scopes, you really should be incorporating chromo into your practice. Random biopsy has consistently, in every study, in every meta-analysis, performed poorly against every other technique, except in one instance, and I'll get to that in a moment. So chromo versus white light, again, they kind of run almost neck and neck, but the chromo, in terms of the ability to detect, tends to run a bit better. You'll find, in general, even with high definition, and again, it just barely reaches statistical significance with high definition. You'll find a few more, right? My own practice is that the other box that it most crucially checks is that it better defines the lesion than white light. So that's really key. You need to be checking both of those boxes. So for the random biopsy method, and I just want to point out that this slide was made, I think, before most of the current fellows were born. It seems that the Mount Sinai insignia is even out of date. The only instances in which random biopsy actually works is in patients with those tubular, burnt-out colons where you cannot get an en-face view, and they have PSC. And that's the Jeté data. It's, I think it's useful information. It changed my practice. But at the same time, if you can't get an en-face view, nothing is going to give you a good visual result, right? Whether it's chromo or whether it's high definition white light. So if you're encountering that, make sure that you're doing very careful sampling and mapping of the colon, and it's almost always in the distal colon where you can't really see so much in those patients. So that's my recommendation. With this era of a visual definition of dysplasia, where you're using the Paris classification, you're looking at the borders, you're looking whether or not it's depressed, is it ulcerated, you're mentioning the Kudo-Pitt patterns. These are all words, but it's actually moving to an era where AI, and there's intense interest in this in the community, where AI can start to say, well, this is a dysplasia and this is not. It's never going to replace pathology, I doubt it will. But it will be helpful for us the same way that AI has been helpful, let's say, for cross-sectional imaging. It's not going to replace it, but it's going to augment it. So you define the lesion. Is it resectable? And again, EMRs now are very commonly done. In my own practice, I err more on the side of using cold smears than hot. And again, it's very satisfying once you define it to resect it. However, if you see something that you think, I'm not going to be able to get this out, don't try to take it out, right? If you're really not confident you're going to be able to do it, like Jim and I were just talking about a case he was referred. A guy says, I don't know if I can take this out. Then you biopsy it and you send it to an advanced endoscopist. You can do a endoscopic submucosal resection where they do an en-bloc removal, and it's much deeper. They can define the margin. They can just describe whether or not they've had a good lift. But you need to partner with an advanced endoscopist to do this. If you can't define the lesion, they can't clear the margin. If it's multifocal lesions and you're doing serial ESDs, if there's any high-grade dysplasia or carcinoma, that's when you call the surgeon, and that's where this talk ends. That's another talk going on beyond there. So this paper we published a couple years ago looking at, it's a multi-center experience. This experience is 45 patients. Now we're up to almost 100 patients amongst all the centers, and we're going to revisit it, looking at what happens to these patients. What is the complication rate? It's a very low perforation rate. These patients do very well. The recurrence rate is really quite low. And so, again, we're continuing to work on this to see what the limits are. When do you stop doing colonoscopies on these patients with chronic colitis? I start the conversation at age 75, no matter what. Same time we do for our general population patients, although technically you have to start it at age 66, right? Because if they have a negative colonoscopy with average risk, at age 66, they're done. They don't need it anymore, right? Patients hate this conversation. And in IBD, they hate it even more because we do so many colonoscopies on these patients, they feel like you're letting them go somehow, right? So you have to be very careful with conversation. If there are comorbidities, if they've had previous dysplasia, if they're in a long-term remission or not, lack of colorectal cancer family history or not, these are all factors that play into it and should inform your conversation with the patient. So what do I do in my own practice? If they have active disease, they are in a completely separate category. They need to be coming back every year. You need objective endoscopic measures, and I'll tell you what I do with mine. You really need to optimize their medical regimen. You need to get them into a remission. Jean-Fred and I share many patients where we do this every year. When they're active, I send them back, and I said, bring them back in a year. Happy to look. And when they're settled, it's just much, much easier to survey them. I have much more confidence. I use a 1, 2 to 3 or 5 year intervals, depending on, again, everything I just described. I do not do random biopsies unless there's PSC in that specific scenario that I described, and I'm unable to get that en-face view. I do chromo, I do a UCEIS and a Mayo score, I do histologic biopsies, and again, I mimic the music study that we have been doing with NOM for the last few years, where I do ascending, transverse, descending, and rectum for every single patient. And again, just to check histologic activity more than anything else. The rest of it is a visual examination. I always suggest doing a high-quality surveillance before a pouch. You really don't want post-surgical remorse. What if it's a lesion that actually you could remove and manage endoscopically instead of sending them to surgery? I manage multifocal or serial unifocal endoscopically. I do not assume that the current guidelines are going to work for all these patients who are making it to ESDs. If they've had a poorly defined lesion, if I had to use piecemeal, I make it clear to the patient that that's, we need to be paying closer attention to them. I don't do EMR. If I expect an ESD is needed, I do a biopsy. I follow them all long term. If they have high-grade dysplasia or carcinoma, call the surgeon. How do you know if you're doing a good job? You should at least have a 10% dysplasia detection rate in your practice. In a referral center like this, it should be exceeding 20%, and I run at about 23, 25%. Dysplasia resection rate should be about equal to your detection rate, right? You should be really trying to remove these as you see them. You should be referring to the advanced endoscopist, and your referral to the advanced endoscopist should exceed your referrals to the surgeon, right? Just a rough measure. What's the issue? What's the problem now, and what's the work to be done? I say this specifically to the fellows. We have no randomized control trials at this point showing that there's any benefit to doing anything that we're doing. There's no validated training program at this point. The Cochrane analysis only showed one tertiary center showing a significant reduction in the risk of CRC with extensive UC by surveying them regularly. So there's still more data that needs to be generated, and let's be humble. The St. Mark's experience shows that they had been working on this all of these years, a 40-year experience, and guess what? All of these scopes have not done as much as you'd think. It takes, for an average risk person, 8 to 10 colonoscopies to get to a CRC or a resectable cancer. For colitis, it's 88 colonoscopies to get to one colon cancer. So we have much more work to do to assess the risk to make sure that we're serving our patients well. Thank you.